Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
This is Lindsay Smith-Rogers. Today, Stephanie Desmon talks to Dr. Francis Collins, the longtime director of the National Institutes of Health, about his most recent mission to eliminate hepatitis C in the U.S. They discuss how it can be done and, more importantly, why. Let's listen.
Dr. Francis Collins, thanks so much for joining me.
I'm glad to be with you on this podcast.
So today I'd like to talk to you about what you've been doing since you left the NIH. And I understand you are leading a White House initiative to end hepatitis C. Can you talk to me about how that came about?
Pretty bold, huh? So I stepped down as NIH director in December of 2021, thinking I was going to have, a 2022 year where I could have sort of a sabbatical, think great thoughts, come up with some ideas about my research lab. That lasted about 6 weeks. And then I got called by the White House and asked to come and be the president's acting science advisor, which was pretty exciting opportunity, although it was also pretty intense. But one of the things you can do in that situation is to look across the entire government investments in science and health and medicine and say, are there some things here that are really ready to go, but they haven't quite been pulled together? And as I looked at the circumstances around us, it was clear that hepatitis C was one of those circumstances that just needed some kind of a push to make it happen. This is one of the most remarkable achievements of biomedical research in the last 20 years. We have a cure for this disease, a very simple one. It's a pill, one pill a day for 8 to 12 weeks, 95 to 98% cure rate, and almost no side effects. Just an amazing achievement. And it's been out there and approved by FDA for 7 or 8 years. But there's still 2.5 million Americans who are currently infected with this virus and have not had access. So there's something really wrong with that. And something needs to be done. And the more I talked to people, the more I got a sense that everybody kind of agreed we ought to have a program, but nobody had figured out what it would be. So, okay, I'll take that as an opportunity. Being there in the White House, how can I bring together all of the government agencies and along the way convince the Congress that this is just something we have to do?
So, as you said, the number of deaths we should have from hepatitis C is 0 at this point, given what we have, but we haven't gotten there. So what's holding us up?
Several things. And yes, you're right, it should be 0, but instead it's 15,000 people dying every year in the United States from this disease. That's 40 people every day. One of them was my brother-in-law who died of this disease about 10 years ago before we had the cure. And it's a very awful way to have your life come to a slow and painful end. Your liver gets basically turned into a fibrotic scar, a cirrhotic scar, actually, as a result of this virus incubating in there over many years. And if you don't get access to a liver transplant, that is fatal. But on top of that, you can get cancer in the liver because of virus hepatitis C. In fact, this is now the most common cause of liver cancer. All of that's now completely preventable with the cure. So why have not people gotten it? Well, it started out very expensive. It was $90,000 for a 12-week course. It's come down a bit because there are now 2 companies that have this FDA approved, but it's still about $24,000 per patient. That makes it pretty out of the reach of people who don't have some support systems. And unfortunately, a lot of people with hepatitis C are not in the greatest place as far as their health care. How do you get hep C? It's from contaminated blood. There are certainly baby boomers who have hepatitis C who probably got it from a blood transfusion before we knew how to screen blood for this. But there's a lot of younger folks who got hepatitis C from a dirty needle, maybe a tattoo needle, maybe intravenous drug, sharing of needle with somebody else who was positive. And this virus is incredibly contagious, so it doesn't take much needle sharing to cause this to be an outbreak around us. And that's the area that's growing the most rapidly. A lot of those people are now over. They're dabbling with drugs, or they're trying to be. And we're putting a lot of effort into trying to help people get free of that circumstance. But it will be truly horrible if we help people get over their drug addiction and then they end up dying of a treatable, curable disease called hepatitis C. So we have to figure out how to reach all those folks. The places where we most need to make access available are people on Medicaid, people who are uninsured, people on Native American reservation where hepatitis C is also quite frequent, and people in the prison system. In some prisons, as much as 40% of the residents are hep C positive, many of them because of the interaction between criminal justice and intravenous drugs. But there are people too. They're our family too. We should figure out how to do something about this. So it's not going to be easy. Let's make that clear. There's also a very clunky diagnostic approach to this. Most people with hepatitis C may not even know they have it because the testing process has not been very effective or very universally applied. It takes 3 visits to the clinic before you're ready to start on treatment because of the way the testing has to be done. So we need to fix that and have the opportunity to do a simple point of care test that can be done in an hour or less. And if positive, results in immediate start of therapy, a test and treat protocol. We're actually well along the way to getting that part done. So all of those things were barriers, not just one barrier, but several barriers, but they are all approachable with a program that could bring together the right resources and the right parts of our healthcare system. And what I learned is going around talking to everybody wants to see that fixed. And I got a very strong mandate from the president saying, okay, Francis, this is a project that needs to happen. I'm counting on you. And that's been my passion for the past almost 2 years, bringing along with me an amazing senior advisor, Dr. Rachel Florence, who is a PhD in health economics, which is relevant here. And more recently, a couple of Hopkins people who have agreed to come alongside as part-time supporters, none other than Josh Sharfstein, your co-moderator of this podcast, and also Dr. Risha Irvin, who's an infectious disease doctor at Hopkins, both of whom have been incredibly valuable sources of information and strategic thinking for me. And we're getting, I think, close to the point this might actually happen. And I can tell you more about what the plan is, if that would be appropriate.
That was going to be my next question. I'm curious what the plan is, and are there barriers such as Congress in the way?
Well, Congress will have to approve this. I don't want to call them a barrier. I will call them a doorway. And I just want to make sure the door opens wide. And we're right on the cusp of figuring out whether that might be possible. So there is a legislative proposal. It is being particularly championed in the Senate by Senator Bill Cassidy, who happens to be a liver doctor from Louisiana, and Senator Chris Van Hollen of Maryland, who just cares a lot about this condition. So that's bipartisan, obviously. The legislation outlines 3 major components. One is to get the testing fixed so that you can do test and treat in one visit. And not waiting for the legislation, we now have very much along the way FDA working with NIH to try to get approved such a point of care test made by the company called Cepheid. And that's looking pretty good. We may very well have that by the summer. The second part is to figure out how to afford the cost, because at $24,000 a pop, most state Medicaid programs are looking at this and their annual budget and going, we just can't do this. And it's even worse in the prisons or the uninsured. So let's come up with a creative way to do this. And this is what's called the subscription model, sometimes called the Netflix model. And it was done in a pilot in Louisiana and it worked pretty well. Basically, the companies are approached to say, would you like to put in a bid for a certain dollar figure that if you get the bid, you then will need to make your pills available for free to anybody on Medicaid who's uninsured, who's in the prisons, or who's in Indian Health Service care. And that dollar figure can be significant enough to make you whole, But it also will be such that the cost per patient, once we've made that deal, goes down much lower than it currently is because you can reach a lot more people. Turns out the drug is very cheap to make, so they can make this kind of an arrangement without actually suffering a lot. In fact, they'll do okay in this. They won't get rich particularly, but they'll do okay. Gilead and AbbVie, the two companies involved, are very interested in looking at this. If we can get that part done, then the access problem, just because of cost, is taken care of. But you still need to provide the kind of healthcare delivery systems so that the testing and treatment can happen in populations that currently aren't necessarily getting a lot of easy healthcare. So there's also funds in this legislative bill to help with the community health centers, for instance, with the prisons, to support some telehealth efforts for Medicaid, and so on, all carefully planned out over the course of a 5-year period. That's the goal. If this can get started, we think in 5 years, we could reach most of those 2.5 million people and get them cured. And we could stop all of the unnecessary deaths that are now happening day after day. So where does that stand? Legislation has been looked at in general terms, and pretty soon the tailed text will be released. There's pretty good bipartisan support in both the Senate and the House. The big question, Stephanie, is what will it cost? And that's where the that's where the Congressional Budget Office plays a critical role. We've already done a cost analysis with a very experienced Harvard economist, and his estimate is this would save the country over 10 years, something in the neighborhood of $6 or $7 or $8 billion. Why is that? Well, because all those people that won't need liver transplants, and they won't need treatment for liver cancer. All of the things that right now are costing our country and our federal government, because we pay for a lot of this, a huge amount of money. So actually, even though running the program itself requires some upfront investment, at least in a 10-year period, you're going to end up saving money. That's our analysis. And of course, I want to hear CBO's analysis and waiting sort of day by day to see whether they agree. If all goes well, if they agree that this is cost savings, it is still possible that we might be able to get this launched as early as next month. But that's a lot of ifs there of all the things that have to go well. But I don't see an immediate reason why that's not possible. As I guess you can tell, I am pretty obsessed about this, so I'm not going to rest if there's something that we could be doing to make that happen.
I understand this has occurred in other countries. Like there's other countries have set out to do this. Can you elaborate?
They have. Australia is a great example. They started a program very much like this back 6 or 7 years ago, and they've come very far along with finding and curing their folks who have Hep C. The United Kingdom is underway already with this. The country of Egypt basically has already done this very successfully and pretty much found everybody and gotten them cured. The Veterans Administration is not a separate country. It's part of our country. Actually got money from the Congress to do this a few years ago. And they very successfully went out and found about 90% of the people that were Hep C positive and got them cured. So this is very achievable. And I don't know why the overall United States should be last on the planet to get this done. We have the resources, which are actually going to save us money. We should just get going and do this.
Well, I hope that your work is successful. It sounds as though you're not going to let it not be.
Not if I can help it.
Francis Collins, it has been an honor to talk to you. Thanks so much for joining me.
Really nice to talk to you, Stephanie. And I hope people listening to this, if they get the chance, will sort of talk it up, because a lot of people still don't seem to know about this remarkable moment. We could actually eliminate a disease, a terrible disease. We have the tools. We just have to get them to work.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith-Rogers, Stephanie Desmon, and Grace Ceciri. Audio production by J.B. Arbogast, Holly Cardinale, Spencer Greer, Matthew Martin, and Philip Porter, with support from Chip Hickey. Distribution by Nick Moran. Production support from Catherine Ricardo. Social media run by Grace Ceciri and Eliza Rosen. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.